I'm honored to be able to follow those two excellent talks and talk with you about a clinically focused topic that hopefully will be of value to you, thinking about post-transplant lymphoproliferative disorders. The truth is that it's not only after transplant that people develop lymphoproliferative disorders. And so one of the reasons that I wanted to bring this topic for discussion is that we all immunosuppress patients, as Kim has highlighted, in part for transplant, but also for other glomerular diseases or other autoimmune diseases. And the risk of lymphoproliferative disorder in the setting of immunosuppression is something that is definitely a real concern. I have research funding from the CUNY Foundation related to this work, and I want to talk with you about the risks and epidemiology of PTLD, as it's called, discuss the management as we currently understand it, and consider some relevant questions that I've been thinking about that help to answer some of the mechanisms and potential ways that we move forward. I want to start with a case, and this is a 47-year-old man who has a history of lupus nephritis. He was first diagnosed as a child, age 13. He's received a total of 3 kidney transplants so far in his life, and the most recent was about 9 years prior to presentation. He was taking tacrolimus with a goal trough level of 5 to 7, MMF at that point of 500 milligrams twice a day, and prednisone. He presented in the summer of 2021 with back pain, night sweats, and a 15-pound weight loss. He works very hard every day, has a physically demanding job, and thought that this back pain, weight loss was all related to his work. But it continued. And so an MRI was done because of the pain, and he was found to have extensive bony disease and adenopathy. One of the lymph nodes was biopsied soon after, and he was diagnosed with stage 4 monomorphic diffuse large B-cell type PTLD, involving many of his lymph nodes and bones. So PTLD is commonly presents as diffuse and somewhat vague symptoms. Many people can have fevers or night sweats like he did, some weight loss, all of the B symptoms like that. Some will have lymphadenopathy, but actually many will not. And many people will present with other symptoms that would take us in a different direction for evaluation. GI symptoms are common. Abdominal or retroperitoneal back pain is common. Even allograft pain, swelling because of involvement of that organ is also possible and common. So I would say that because of PTLD developing around lymph nodes, but often being or expanding into extranodal spaces, the symptoms can be broad. And even at times when it's expanding quickly or not diagnosed early, can be causes graft dysfunction if in the allograft, or even a sepsis-like process with tumor lysis syndrome. We know that Epstein-Barr virus is an oncogenic virus that drives many of the cases of PTLD. EBV is a herpes virus that most of us, 85–90% of us, get exposed to when we're children by the time we're teenagers. And it's an exposure through typically saliva. The mucosal epithelium in the nasal or oropharyngeal region is the most common exposure spot. And then the EBV virus integrates into the B cell. That viral entry in the B cell doesn't just stay in the cytoplasm, but actually then the EBV can integrate within the genome of the B cell. And those B cells will continue to maintain the EBV genome as it evolves, so that it moves from a naive B cell into a blast B cell population, and the virus moves from initially an active setting to a latent setting. If there is a change in immune health of the person, whether it's an infection of another sort, a stressor of some sort, or immunosuppression, it's possible for that EBV to then reactivate and begin to drive replication of those B cells or plasma cells. If there's not enough T cell surveillance, then that EBV can drive the B cells to develop into a post-transplant lymphoproliferative disease. You'll notice that there are many sites where this can develop. The most common include the GI tract, the organ transplant setting, and that could be liver or kidney or elsewhere. Lymph nodes are possible, and even CNS lymphoma, which is very aggressive, is something to be considered. Normally, our immune system does a great job of surveillance, including for viruses and cancers. And yet, when we add immunosuppression, we reduce antigen-presenting cell number and function, as well as T cell surveillance. And by doing so, this all leads to a cascade of EBV and potentially then B cell or plasma cell progression in this condition. Some of the significant risk factors for PTLD that we know of are at the top of the list. And as we go down the list, those are less supported, but still identified as possible risks. And so we know that people who come to transplant or come to immunosuppression and do not have IgG positive against EBV, meaning seronegative, are at higher risk, significantly higher risk. Those who receive EBV positive donor or get exposed to EBV infection soon after transplant are a much higher risk. Variants of LMP1 gene sequence are definitely at a higher risk, and yet that's not something that's commonly clinically studied. From an immunosuppression point of view, those who have T cell depletion for their transplant or receive ongoing immunosuppression, whether that's for a GN or for transplant, are definitely a higher risk. And that cumulative risk then raises the ongoing cumulative risk of PTLD. The type of organ transplant is definitely something to consider. And we as nephrologists often think of kidney transplant as the main area to consider. And yes, they're the most common population of patients to develop PTLD just because of the absolute numbers. But yet, as you'll notice here, kidney transplant recipients are the lowest of all organ transplant recipients for risk of PTLD. As you rise from kidney through pancreas to liver, heart, lung, and then multi-organ transplants, you'll notice that up to 20% of multi-organ and intestinal transplant recipients develop PTLD. That's a reflection of the seronegative risks at a younger age. As we know, children and adolescents who are transplanted are at much higher risk, as well as the immunosuppression over time. I'm not going to talk much about stem cell transplant recipients, and yet those patients also have specific risks. The most significant risk for stem cell transplant patients, in addition to what we've talked about, are those who have a one haplotype match from their donor. If we come back to lymphoma in the setting of incidence, lymphoma is one of the top 3 most common cancers after kidney transplant. And as we consider the time from transplant forward, there's basically a bimodal distribution of risk. Early, the first year, most people who develop PTLD are those who are seronegative at the time of transplant. And that's most reflected here on the right graph. Those who are seropositive are more likely to develop a later stage PTLD. And sometimes that later stage PTLD isn't associated with EBV. So you'll notice that there's that marked risk in the first year, it dips down in the second to fourth year, and then starts to rise over time after that. That leads to lymphoma being the most common cause of cancer death in our transplant recipients, and cancer is now the second leading cause of death overall. So we know it's a significant issue. And like I've highlighted, those kids and adults who are EBV naive at the time of transplant have a 2-fold higher risk of PTLD in the subsequent year or more. You'll notice that much of that risk rises in the first year. That lifelong incidence of PTLD, depending on the variables we've discussed, are somewhere between 2 and 20%. Unfortunately, there is no change in the incidence. There has been no change in the incidence over the last 30 years, despite, or maybe because of organ transplant patients surviving longer. Most of the PTLDs are B-cell lymphomas, and that incidence in our transplant recipient population of DLBCL is 12 times higher than the general population, much related to those risks that we talked about. When treated, patients have a progression-free survival of only about 4 years and overall survival of about 6.5 years. That is blunted to some extent compared with the general population, and we'll talk more about why. So if we think about post-transplant EBV monitoring, knowing that EBV is a significant risk, those who are naive at the time of transplant, it is advised that we check EBV PCR, DNA PCR monthly for the first 6 months or until maintenance immunosuppression is achieved with no more changes, and then space it out as appropriate every 3 to 6 months. I believe that the Seattle Children's team continues to have a monthly protocol for the first year and then follow from there. On the adult side, we've been continuing to do EBV PCR for at least the first 6 months and then at least every 3 months after that for the rest of the year and annually from their point forward. Of course, if you see any evidence of infection, checking for serologies to see if someone has converted is valuable. And why is that the case? Well, there's an evolution of the lymphoma cells from initial infection, which is often considered a plasmacytic hyperplasia, that EBV is driving a large population of polymorphic cells. Almost all of those have EBV expressed. As that population then narrows to a more destructive population of cells that continue to be unregulated in terms of cell turnover, those polyclonal cells become monoclonal. And it's that monoclonal population of non-Hodgkin lymphoma, the diffuse large B cell being the most common. Those are the biggest risk and the population that of cells that cause the greatest destruction. Less commonly are Burkitt lymphoma or a plasma cell or a T cell lymphoma. Those make up less than 5% of the total. And Hodgkin lymphoma is also a monoclonal population that is destructive, but we don't often see that just because of how often people have previously had EBV. So if we transition to thinking about management as currently recommended, the first thing I would recommend is just to reduce the immunosuppression. Most often, reducing or stopping the antimetabolite enables the T cells to do better at tumor surveillance and control. Decreasing the CNI or mTOR goal can also help, and consider as low a dose of steroid if appropriate. That brings about, depending on the population you study, 50% benefit. And yet many people will break through and progress. And so the next step in the treatment plan would be rituximab therapy. And rituximab targeting the B cells, in this case, mostly the tumor population and not the normal B cell, can be effective, but yet it doesn't always work. And so then adding cytotoxic chemotherapy like R-CHOP can be even more effective. And we'll talk about some of the data with that in a second. Those that don't respond adequately could be eligible for other treatments like adoptive immunotherapy with EBV-specific cytotoxic T cells. That is a hard treatment to find, and it's costly. And so thinking about alternatives when people really get sick is an important consideration. And the very end of the considerations include stem cell therapy or CAR T cell therapy, and we'll talk about those as well. There have been 2 randomized controlled trials studying the application of rituximab plus chemotherapy, mostly CHOP therapy, in the last about 5 to 7 years. And you'll notice at the very top of this, the prospective phase 2 trials of rituximab monotherapy have achieved an overall response rate between 44 and 64%. Reasonable, but not great. And the overall survival is in the realm of similar. So that leads to the need for adding chemotherapy for many people, either because they relapse or they never responded to begin with. And so with treatment using a rituximab plus CHOP therapy in the PTLD1 and then subsequently the PTLD2 trials, there was better overall response rate of about 88 to 90% and a median overall survival of 6.5 years. Better than with rituximab alone. And so those were promising in the sense of having something to treat patients with. And it also, PTLD2 study enabled an adjustment of the intensity of the CHOP to really back off when there seem to be lower risk patients who may achieve remission with rituximab instead of jumping immediately to the CHOP therapy. Unfortunately, if someone is resistant or relapses after R-CHOP, there is really no consensus on how best to treat someone. And that often can include other chemotherapies. But the question then comes up, especially in the current era, of whether we could use engineered cell therapy to target those B cells that have developed into PTLD. So I'd like to come back to our case. And in this case, I became involved in this patient's care when he was diagnosed and came to Fred Hutch. And so we stopped his antimetabolite, his MMF. And because of the extensiveness of his disease, he initially received our CHOP. He developed a partial remission with that, but had ongoing disease in his right femur, as you can see here on the PET scan. Unfortunately, the bone pain and neutropenia limited the intensity of that regimen. And then 2 months later, he redeveloped B symptoms. And so with that, he needed more treatment and received rice therapy, but only for 2 cycles. And that was complicated because of confusion with the ifosfamide treatments. So once again, the chemotherapy has its side effects that we need to face. And so because of the significance of his early relapses, he was considered for either stem cell therapy, stem cell transplant, or CAR T therapy. And to note, all immunotherapy trials have excluded organ transplant recipients because of their immunosuppressed state and complicated conditions. And so we didn't really have any basis for which to make this decision. The decision was to try to move forward with a stem cell transplant, but in the course of that time, he had progressive disease and became so weak that he no longer was considered a candidate for stem cell therapy. So we pivoted to recommending, with limited knowledge, using CAR T therapy against his PTLD. For those of you who aren't as familiar with CAR T cell therapy, the idea is to remove a blood sample, a large blood sample from the patient, and then filter the T cells from that blood sample. Take the T cells and insert a chimeric antigen receptor, in this case, a CD19 chimeric antigen receptor that would target the B cells, grow those out in the lab, and then reinfuse them into the patient in order to attack the cancer. That works amazingly well and has led to great improvements for people in the general population who have lymphoma and other chimeric antigen receptors for leukemia. And now it's being studied and in phase 1 through 3 trials in different solid tumors as well. It's a different question when someone is on immunosuppression with a transplant. And so in his case, we needed to think about how could we attain enough T cells while being on immunosuppression to make it effective enough to then grow out and give back. And so I chose with the team to hold his tacrolimus 40 days prior to leukapheresis while continuing a low dose of prednisone. And then he received, like the standard of care, a bridging therapy of immunosuppression followed by a lymphodepletion in order to create a space for infusing the T cells with cyclophosphamide and fludarabine. So this went forward and he did reasonably well. 7 days after his infusion, he experienced fevers and a headache consistent with cytokine release syndrome, cytokine release syndrome, and ICANS, basically a neurologic syndrome that can be associated with infusion of chimeric antigen receptor T cells. But thankfully, with just IV fluids and mild steroid dose of about 20 milligrams for a couple of days, he was able to recover those symptoms. Because of the concern that he may be developing a rejection, as we had no previous experience, we tested donor-derived cell-free DNA, and it was very high at almost 8%, with normal being less than 1%. And so naturally, we were concerned that he was rejecting, and you'll notice that his creatinine was actually higher than, followed that track and was higher than normal, jumping up from about 1 to 1.3. But because of the significance of his health condition, he wasn't interested in a biopsy, and so we just followed forward. And you'll notice that thankfully, just with treatment progression, the cell-free DNA test result dropped without anything else down to 0.14%. And the reason why I think that he had this initial elevation in cell-free DNA was more because of the endothelial injury from the bridging treatment and not a rejection. So he continued on with follow-up, and thankfully, at some point, we needed to consider restarting his tacrolimus. And so because he was doing reasonably well, we restarted his tacrolimus 3 months after having noted that he had achieved a complete remission. We were able to track the number of circulating chimeric antigen receptor cells in his bloodstream with the FLAP-EF1 alpha biomarker. And at 3 months, it was still at 91% of what was initially infused. Unfortunately, 8 months after his infusion, he developed pain in his right hip and buttock area, and so another PET CT was done, and it showed a new mass. It was biopsied, and it was consistent with PTLD, but what was interesting is that it was only there, nowhere else. He had ongoing circulating chimeric antigen receptor cells, but had no CD19 positive lymphocytes in the blood, to suggest that his CAR T therapy was controlling the tumor with the exception of this one location. And so he was treated in that one location with radiotherapy. And then we continue to follow with PET CTs and labs. And thankfully, he has done remarkably well. So since that 8-month relapse, he has had stable serum creatinine at about 1.2, including up through this week, and has had no signs of rejection while maintaining complete remission. His chimeric antigen numbers by circulating cell numbers diminished to basically undetectable by 1 year, which is expected. And so we continue to follow him with the question of how long will he maintain control, knowing that he does have, mild immunosuppression, but definitely immunosuppressed enough that this population of B cells may recur. So a number of questions came up from there, including what is the safety and efficacy of a chimeric antigen receptor therapy for organ transplant recipients? Is there a non-specific immune activation that could lead to allograft rejection? Could chronic immunosuppression blunt response? And what's that impact on duration of response? And so I worked with Andrew Portuguese, who at the time was a fellow and is now an assistant professor here at the Fred Hutch, on a systematic review and the case report that I just shared with you. And at the time that we did this review, there were a total of 17 cases reported in the literature. 12 of those were male and 12 of those were kidney recipients. Most were Ann Arbor stage 4 DLBCL, and most were EBV negative at the time of diagnosis. There were a number of off-the-shelf CAR T products that were used. And so we queried the entire database as we could and studying Google Scholar, Embase, and PubMed, and only found 10 manuscripts at that point. So it was a relatively limited population that we're talking about, with the kidney transplant population representing the majority. Like I mentioned, DLBCL was 15 out of 17, and thankfully the overall response rate was excellent, 91.6% with those patients that were reported. The duration of response was quite abbreviated, though, at 4.2 months. And so it did raise the question of whether or not we were going to be able to achieve the goal with this. Toxicity was manageable. There were 4 reported cases of rejection, but none progressed to allograft failure. And a similar level of cytokine release syndrome and ICANS, both in terms of total number as well as grade, compared with the general population, controllable with symptomatic therapy and or steroids. Other complications are similar to what we find in the general population listed here. And for the sake of time, I'm just going to come back to the discussion about the duration of response. And the ZUMA-1 trial was a general population study of chimeric antigen receptor treatment for lymphoma, and 83% of patients achieved an overall response rate, 58% with complete remission. And that's similar to our very small cohort that we were able to study. Unfortunately, the duration of response was half of what was seen in the general population. And so what we're seeing, we think, is that CAR T therapy is feasible to treat relapse and resistant PTLD, but the combination of CAR T activity because of immunosuppression, the potential off-target allograft injury, though, seems that that's a limited concern. The cost is definitely concerning. The average cost for an infusion is in the range of $500,000, so it's a major cost to consider. And yet, if we could understand the best use of immunosuppression to help our patients, this may be an alternative for those who have evidence of early relapse or refractory disease. So to finish, there are many future questions, including what the roles of viral infections, immunosuppression, and genetics play in the development, progression, and resistance to PTLD. And can we better identify those risks even at the time of transplant or the time of diagnosis of PTLD? And so in order to better focus, I've been working with Andrew Portuguese on this question, and we just received a grant from the CUNY Foundation to study PTLD tumors and the tumor microenvironment to determine whether there is evidence that the tumor microenvironment, the tissue, mRNA, or other transcriptomics and proteomics that give us a better understanding of treatment resistance and relapse at the beginning. So we'll take the tissues that are FFP embedded, and then leverage the combination of Codex and Visium to study the protein and transcript, the transcript and protein markers on these tumors to better discern whether there are distinctions in the tumors for those who respond to rituximab versus R-CHOP versus having refractory disease. So those are the next steps that we anticipate working on using the DNA coded antibodies for Codex. It allows you to basically apply 40 to 50 different antibodies to a tissue sample and identify then the proteins that sit on the surface of different cells, and from there use graph-based AI to separate out different cells within the same region. Because of the heterogeneity of tumors, it's valuable to have a broad assessment of different cells early and then focus in on patterns that may help better predict the neighborhood interaction between cells, as well as then potentially cell-cell interaction, giving indication of subsequent response to treatment. So to finish, PTLD is commonly driven by EBV. Transplant recipients are 6 times higher risk for PTLD, specifically DLBCL. It's a leading cause of cancer death. It probably is the leading cause of cancer death now. And the standard treatment approach would include reduction in immunosuppression, use of rituximab where appropriate, and then addition of the CHOP therapy or other chemotherapy where needed. There may be a role for CAR T engineered cells, especially in the salvage condition, and definitely more to learn and figure out. I really am most appreciative of the patients who continue to contribute in multiple ways to this, including their input, their samples, their willingness to take risks for themselves, but more importantly for the population, and for our teams that work together to try to advance our knowledge and help people out. So thanks so much. I'll take any questions knowing it's right at the end of the hour.
Thank you, Chris. Thanks for doing this really innovative work that's so clearly connected with your clinical work and experience. There's a question from Taka in the chat, wondering about how selective CAR T therapy is, if there's any concern for allograft rejection.
Right, Taka. So CAR T therapy can, I think, increasingly be precise and even more precise than it has been by identifying the best surface or maybe even intracellular marker to target. CD19 was one of the first to be studied, and it is quite precise for B cells, but yet naturally normal B cells will also have CD19, so that therapy would lead to cell death of normal B cells as well as the lymphoma. With better treatment, with better study, they're increasing more precise protein markers that identify PTLD separate from normal B cells, and like I mentioned earlier, that the risks include the LTAM1 marker and other surface markers that we may be able to then generate a chimeric antigen receptor with. We haven't seen much of any significant allograft rejection. So unlike checkpoint inhibitors that Kim talked about, we're not seeing rejection play out with chimeric antigen receptors. And I think there's even more value in considering using chimeric antigen receptor treatments for both cancer treatments, but like Kim highlights, leveraging the same concepts for autoimmunity and treatment or prevention of rejection is going to be and continues to be a major interest across the immunologic community.
Well, Iris, do you have a quick question?
I do. Yes. Hi, Chris. Thank you for the talk. My question is actually regarding the EBV viremia, without PTLD yet. So we have these monitoring protocols, of course, for our EBV naive patients because they're at higher risk in developing viremia towards PTLD. So my question is, other than preemptively decreasing their immunosuppression so that they don't develop EBV viremia or worsening of, are there any other management strategies that you found helpful? Like, for example, we've seen maybe Valsite or rituximab when EBV is increasing, because I get questions about this with, general nephrologists when they're continuing the monitoring of EBV PCR per our recommendation. So other than knowing that it's there, are there any other intervention other than decreasing immunosuppression? And I can also get the opinion from pediatric colleagues who may see a lot more EBV naive patients.
Right. Yeah, I think that we learned from each other, including I surely continue to learn from the Seattle Children's team. My experience would lead to say that naturally the first is to decrease and then discontinue the antimetabolite if you think it's safe. The second is to potentially address that ongoing need for some immunosuppression while addressing the growing EBV population. You could trial valganciclovir with modest potential benefit, though there have been case studies that showed benefit. You mentioned rituximab. You can definitely consider early rituximab treatment if that EBV titer continues to rise, especially 10,000 copies or higher. And others have used IVIG or EBV specific immunoglobulin. It's harder to get, but have been successful. Typically, if you're going through those steps, you're getting into the realm of the polymorphic, if not the monomorphic PTLD, in that process of the EBV titer rising anyway. So the therapies kind of cross over into how you would address the early phases of PTLD, even if you don't have a biopsy yet. So it is worthy of then thinking about how could you identify any early PTLD, and CT scan plus or minus PET scan are the appropriate next steps in that case. I'm wondering if anybody on the children's side wants to speak to their experience as well. It's a good question.
We'll close there unless there's a very quick comment from one of the folks from pediatrics. But I think a really, really rich discussion. Thank you for that talk, Chris, and thanks to all of our presenters for really, really rich, deep content today.